Marisa, it's an absolutely fascinating question, and that is where a lot of patients end up being exceptionally frightened and exceptionally concerned, because they automatically think, if I've got breast cancer, I have to have a mastectomy. Now, a mastectomy these days is the default operation for breast cancer. There are certain times where one has to perform a mastectomy if it's a large tumor or if it's in lots of areas of the breast. But we well into the advent of breast conserving surgery, and the outcomes of breast conserving surgery, i.e. a lumpectomy, followed by radiation, is exactly the same from a survival point of view as to a mastectomy. Okay? So fortunately, in at least 60 to 70% of our patients, we are able to perform breast conserving surgery, where we will take the lump out. Then we can reconstruct the breast either by a breast lift type operation, breast reduction operation, or we can bring in a little bit of tissue from underneath the arm or from the upper part of the abdomen. Okay. So, the advances in our understanding of the disease have been able to shift patients away from mastectomy to lumpectomy and radiation in the vast majority of patients. Even in patients that do need a mastectomy, like for example yourself, because of the severity of your disease and the multifocality of your disease, we're often able to do an immediate reconstruction. Okay? So what we would do is we would do the mastectomy, and these days one's able to leave behind the skin and the nipple in the vast majority of patients, and it's completely safe from an oncological point of view. And then what we would do is an immediate reconstruction. And there are lots of ways to do it, okay? But one of the simplest ways to do is to, once we've removed the breast organ, to replace it with a similar sized breast-shaped implant. Sometimes because we've lost a lot of skin, we might need to use a device called a tissue expander, which is an inflatable device that we would put in, and then we would slowly stretch the skin out, okay? And then also there are lots of autologous options. Autologous options are using the patient's own tissue. There are flaps from the abdomen called a DF flap. There are flaps from the inner thigh called a TMG or a TUG flap. And then also flaps from the upper part of the buttock and the lower part of the buttock, S-gap and I-gap. Those are the common donor sites. Very uncommonly these days, we will use the muscle from the back. That's called the latissimus dorsi flap. But these days it's kind of reserved as one of the last lifeboats for breast reconstruction. Because it doesn't give much volume, it makes the arm weak and stuff like that, The major problem with using one's own tissue for breast reconstruction is what we call donor site morbidity. So wherever we've taken a piece of tissue from, there's going to be a scar there because we cut it. If it involves the muscle will always be a little bit weak in those areas. So there are definite indications for different types of reconstruction, but internationally there's a big swing away from the complicated autologous operations, because they also take a long time. To do a DF flap from the abdomen, it takes about 6 hours to do one side, and if you're doing both sides, about 8 hours or so. With the advent of good prosthetic-based reconstructive techniques, i.e. being able to put an implant in straight away, there's been quite a big shift away from those long, complicated operations. Sure, there is still a place for them in certain patients in certain circumstances, but more often than not, one would be looking to do something that's a little bit simpler, a little bit shorter, potentially a little bit easier to do in those types of situations. Look, fortunately, funding internationally for breast reconstruction is freely and widely available, okay? Interestingly enough, in about 40 states in the US, if a general surgeon offers the patient a mastectomy and performs the mastectomy without a consultation with a reconstructive surgeon, that's a criminally liable felony of assault, okay? Which, because sure, we might not be able to do the breast reconstruction at the same stage, but every woman must have access to to a breast reconstructive surgeon during the course of her illness. Unfortunately, it's not seen as cosmetic, and it isn't a cosmetic procedure. It's a reconstructive procedure, exactly the same if I have to reconstruct a leg after somebody's fallen off a motorbike. So we have very good funding for breast reconstructive, and it's a prescribed minimum benefit illness. Breast cancer and the associated treatment of it, including the reconstruction of it. So fortunately, it's ubiquitously available. Some of the lesser medical aids do have issues with potentially paying for, say, something on the other side to make it match or something like that. But as the Association of Plastic Surgeons in South Africa, we've negotiated very appropriately with just about all the funders, and it's ubiquitous amongst just about, I think, about 85% of the funders that they will pay for whatever needs to be done. We did discuss the various different types of breast reconstruction, and most of the time we're able to perform breast reconstruction immediately, i.e. at the same time as the cancer's removed. Okay, and that would be in the vast majority, over 90% of patients. Okay. There are very, very few contraindications to breast reconstruction. The only absolute one is the potential patient's fitness for it, okay? Because it does add a bit of extra time to the operation, okay? And if a patient isn't fit enough to tolerate an extra half an hour, an hour in theatre, then we would not perform the breast reconstruction at that stage. Or from an oncological point of view, if we're unsure about what's happening with the cancer, the surgical margins and stuff like that, that's when we would not perform a breast reconstruction. We'd make sure that we've sorted the oncology out appropriately, and then we'd come back and then potentially if the patient wants to perform a reconstructive sequence in the delayed setting. So once they've finished all their cancer treatment, chemo, radiation, whatever the patient needs, then we'd bring them back 6 months after that and then start whatever reconstructive sequence we are going to do. So pretty much everybody is a candidate for breast reconstruction. And then obviously, there's patient choice as well. There are some patients that are not interested in having a breast reconstruction, and that's absolutely fine, and they'd rather wear an external prosthesis in their bra, and I get it, I understand that, We know from a lot of statistical data and ResQ data, which is a quantitative quality of life scoring system, that patients that do have a reconstruction tend to have a better quality of life score post-operatively than patients that don't. And there are various different psychosocial factors, physical factors, psychosexual factors, and the whole milieu of how a patient feels. But we do know statistically that patients that do have a breast reconstruction psychosocially tend to perform better. And we've got very, very good measuring tools to do that. So I always try and encourage my patients, listen, you must strongly consider having a breast reconstruction. And even if we decide that we're not going to do a breast reconstruction in the immediate setting, I'm never going to do anything from an oncological point of view that's going to burn any bridges, that we can't do a breast reconstruction should the patient decide that they would like to have a breast reconstruction at some stage in the future. Campaigns of wear your scars proudly and stuff like that, I've always strongly disagreed with. I remember I was talking in Australia at the Australian Plastic Surgery Congress about some of my direct implant reconstructive work, as well as quite a lot of my other stuff. And it was one of their sort of fair lady type magazines, a local Australian magazine. And it was in October, so it was Breast Cancer Awareness Month, and there was a woman with conventional mastectomy scars, chest to chest, on the front of this, wearing your scars proudly. I've never seen anything so horrific in my life before, because we're so far beyond that. That is 25 years out of date to put a patient into a situation like that. Look, there are potential cases that we might, for temporary time, not be able to reconstruct a patient. But, that's something that's out of date. We'll just get over it, in my opinion. I'm quite matter of fact about that and where I stand. When it comes to cutting something out of the breast, be it a lump or doing a mastectomy, we have to make a scar. But what we are able to do these days is minimize the extent of the scar. So we can use small little cuts. I mean, I can do a mastectomy on a medium-sized breast through about a 75 millimeter cut. So we make a cut around the bottom of the areola with a short little extension to it if it's a smallish breast. Often if patients have got a large breast, then we will do what's known as a type 4 skin and nipple sparing mastectomy, which is a mastectomy through a breast reduction type pattern, and that leaves you with a cut around the nipple, down the breast, and underneath the breast, like that anchor scar. The reason why we do these incisions is that they are aesthetic or cosmetic operations that we apply to the removal of the breast. So it leaves scars in as aesthetically pleasing areas of the breast as possible. Also, if we're doing a lumpectomy, and let's say, for example, we've got a tumor in the upper outer quadrant of the breast, we're not going to cut there or the upper inner quadrant. We're going to cut maybe around the nipple, and then we're going to go underneath the skin and then take the tumor out. So we don't have a big cut in the cleavage area. Just as much if it's in the upper outer quadrant of the breast, we'll cut on the side of the breast, almost underneath the arm, go into the breast and then take it out. So we're trying to leave the breast mound scarred as little as possible. Then obviously the post-operative management is also very, very important when it comes to scarring. And as plastic surgeons, that's part of what we would automatically do. And there are various different ways to manage scars, but it involves taping and massage and silicone dressings, plus or minus maybe some steroid injections and stuff like that. So ultimately, usually when the scars have healed, they're in aesthetically pleasing areas and they are as fine as possible, and the scars will often be imperceptible. Also, one of the good things is if patients do need radiation is actually a very effective treatment for scars, and the scars on the radiated breast often you can hardly even see them, So if I'm radiating the patient's one side, I'm always much more concerned about the scarring on the other side, because I know the radiation is going to help us out and sort out the scarring on the side that the patient's going to need radiation. The environment of breast cancer and breast cancer reconstruction is complicated, and we all work together in teams because it's multifactorial looking after these patients. We need an oncologist, a radiation oncologist, health and wellness and survivorship, somebody to remove the breast cancer, somebody to reconstruct the breast. We need some post-op physiotherapy, lymphedema control. So we all work in plus the imaging and the radiology. So we work in multidisciplinary teams. So first and foremost, as a patient, make sure that you are being treated in a multidisciplinary team environment, because the treatment is going to be much better. Okay, that's step number one. You can't go to somebody that just does the odd breast cancer from time to time, because the chances of it being done appropriately are not as good as if you are treated in a multidisciplinary team. So that's number one, fait accompli. It must be a multidisciplinary team. Okay. When it comes to breast cancer surgery, okay, traditionally the way it's worked internationally is that you've had a general surgeon or general surgeon with an interest in breast that removes the breast or removes the lump, and then you have a plastic surgeon that comes in at the same time and does whatever reconstruction needs to be done. Okay, so it's a two-person or two-surgeon team. There's been a shift remarkably in the last 8 to 10 years internationally towards what's known as oncoplastic surgeons. Okay, so therefore it's one surgeon that does the breast cancer expatriation and the same surgeon that does the reconstruction. South Africa is a little bit behind the times, and we still work as a majority in a two-surgeon team. Okay, but the shift internationally is towards a one-surgeon team. So that's why they've started internationally this qualification that's called an oncoplastic surgeon. In most geographical distributions, it's a master's in surgery. So you need to be a qualified surgeon, either a general surgeon or a plastic surgeon first. And then you do this 2 to 3 year master's in oncoplastic surgery. And then you become a specialist breast oncoplastic surgeon. So then you're able to do something. It's something that I have always wanted to do, because I've always felt potentially that there's a little bit less anxiety with the patient dealing just with one surgeon rather than having the general surgeon saying, okay, I'm going to lock your boob off, you need to go and speak to the plastic surgeon and he's going to tell you how to put it all back together. And also it's starting to be borne out in the literature that a lot of the reconstructive techniques are being able to sort of be minimized because of the fact that the reconstructive surgeon has got control over the cancer. Previously, the thinking was, well, the reconstructive surgeon is not going to take enough out if he does the cancer surgeon because he's worried about the reconstruction, and that's all he's thinking about. But as an oncoplastic surgeon, you're trained to almost compartmentalize the operation into the cancer side of the operation, but then also the reconstructive side of the operation. And if you're doing it as a single surgeon, you're able to automatically plan a little bit more accurately what you're going to do reconstructively as to where you're going to cut to the expaturative surgery. And it is definitely the way forward. Unfortunately, as plastic surgeons, the vast majority of us have done at least a minimum of 2 years of general surgery training before we start plastic surgery, and then there's 4 to 5 years of plastic surgery. So we're generally quite well qualified and trained general surgeons before we do that. In my circumstance, I had to wait before I became a plastic surgeon, and I waited for 4 years. So I was basically almost a fully qualified general surgeon before I became a plastic surgeon. And yeah, it's the modern way that things are done, and things need to change with the times, you know. From a patient's perspective, I think the most important thing is, first and foremost, that you are treated with a multidisciplinary thing, and then secondarily, that you connect with the surgeon that is doing the work for you. Oncoplastic surgeon, general surgeon with plastic surgeon, and you feel supported by the team. You feel that your questions are answered, you feel that you understand what's happening with your treatment pathway, because the treatment pathway is unique and particular to each individual. Sure, there might be a lot that's similar between the next patient that I would treat, but there are also some differences, and there's also choice as to what one wants to do, you know. There are patients that are great candidates to have a lumpectomy, but they are convinced that they want to have a mastectomy, and there's nothing wrong with that, okay? It's not necessarily what would be the most indicated treatment, but you know, often one sits in a situation where there's a 55% we should do this, 45% we should do that, and one needs to make sure that these decisions are made with patient involvement and with the team involvement, because there's no right way or wrong way to do a lot of this type of stuff. The only right thing is to make sure that the cancer management is 100%, okay? That is the only right way to do it. And that involves the cancer surgery, plus or minus the adjuvant radiation, plus or minus the chemotherapy. That is fundamental. That cannot be changed. But there are options as to whether one should have a lumpectomy or mastectomy, what type of reconstruction somebody wants, and how we're going to go about doing it. Immediate, delayed, all those scenarios. And all of that needs to be discussed with the patient, and the patient needs to be included in the active management of their disease process. Because then they're not going to just survive their cancer, they're actually going to thrive through the process. And there's a lot of interesting new literature coming out about breast cancer thrivership, not just survivorship, because it is an imminently survivable disease these days. Sure, the treatment pathways can be very miserable and they can be really, really hard, okay? But it is a life-changing event, and after a life-changing event, one doesn't want to just survive a life-changing event. One wants to actually reflect on what was good about one's life before, what's different about it now, and how one's going to go forward and actually learn from an event like this and then thrive through it. And I think it's a really, really nice way of looking at the breast cancer journey. Because sure, like any journey, there are going to be times that are really, really tough. You know, one might be, you know, going on and I often describe that we're going to go on a journey from Johannesburg to Cape Town. We've plotted our route. Sometimes it's going to be straight down the N1. Sometimes we're going to take a scenic route, okay? Sometimes we're going to go on a long route through Namibia, and we're going to see some of the deserts and stuff like that. But ultimately, we'll get to Cape Town in the end, and it will be a sunny day. But there can be potholes along the road, flat tires, broken down vehicles. That's what can happen on a journey, you know? But if one's together as a team and there's support, then it doesn't really matter. It's one of the adventures of life. most difficult thing of this is getting a diagnosis of breast cancer, and you've been there, and it feels like, your world is just falling apart, which it is, okay? Because it is a significant diagnosis, and it's a imminently, it's a severe disease in certain circumstances. But like anything, when it comes to medicine, the more we know about it, the better we get at treating it, okay? And the sooner we get it, the easier it is to treat. So as a take-home message, if you are at all concerned or worried about something in your breast, the sooner you do something about it, the easier it is to find out what it is and to be able to treat it properly.